I think it should be a giraffe and not an elephant, just so you know. All right, well, thank you for having me, and I appreciate SAGES and the moderators for the privilege of the podium. And so what I'm going to try to do is shoot a bunch of numbers at you to hide some things, and then talk here at the end about how we can ultimately pay for the tool that we've heard so much about today and may potentially continue to be used in the future. These are my disclosures, none of which are germane to the talk today. So what are some of the assumptions we make when we talk about cost? And my colleague will come up and throw some of these back at me, so we'll put them right out in the room in the beginning. And the assumption is that robotics will always cost more than lap, which will always cost more than open. And then we look at hospital costs, and depending on many factors, so patient demographics, procedure type, length of stay, where your patient population comes from, whether you have third-party payers, whether you have Medicaid payers, all of those things factor into your hospital costs. Shorter hospital length of stay is a good thing. That's an assumption, right? Because most hospitals want shorter length of stay in order to increase volume and increase bed turnover. Some hospitals, based on insurance, would rather have that patient stay 4 days because they get paid for all 4 days. If you send them out in 2 days and they don't have a patient to replace that one, then ultimately they may be losing money. So that's an assumption we'll operate under. And then there are more volumes equals more money, and outcomes don't change. So that's the biggest assumption, right? In other words, if we spend more to get the same, then what are we doing? But if we spend more to get more, then we may be adding value, and value is a completely different calculation. So who's primarily responsible for controlling costs? Well, I think we as surgeons take a great deal of responsibility, but it's not just us, right? Hospitals, third-party payers, the government, et cetera, all are responsible for trying to control costs. And if we're responsible for controlling costs, shouldn't the hospitals know their costs and help in that effort? I would encourage any of you, if you haven't already tried, to get cost data from your hospital. It is an amazing task, almost impossible. And for the hospital to calculate what it is, either per patient or per robotics case, including patient throughputs, lengths of stays, and outcomes, they really have no idea, the majority of the time, what their actual costs are. So then, if they don't know what their costs are, how can you build the best cost-conscious model? And that's what we have to kind of think about. So if we're going to be the ones to impact cost and choose not the robot versus the robot because we think that's the sole motivator of cost, what kind of things can we control? Well, we can control our education and training and experience, and you heard Danny and Brent and all those folks talk about credentialing and the experience necessary. Materials management and utilization, there are multiple folks that can show you how to streamline your process and potentially save money when using the robot. Cost-effective decision-making should be true of any operative intervention that you proceed with, robotics or otherwise. So I think that's just something that is germane to our practice. And then also looking at your patient outcomes and your quality of life reporting in your particular patient population, whether that be in a smaller community hospital or in a university hospital. And obviously this is a plug for the AHSQC, right? Because that's one way, at least in hernia repairs, where you may be able to track and compare that data. How about health systems being responsible? Well, they have controllable variables too. They can try to control you. That's one way they can do it. They can also do it by purchasing agreements and contracts, right? So if they invest intelligently in their stakeholders, i.e. their surgeons and their patients, sometimes that takes money to make money. Other health systems may choose instead to just never spend any money and try to save by cutting costs only. Somewhere in the middle is probably the right answer. They institute and bring in people to work on lean policies and procedures, which started in the business world and moved to the healthcare system. Team-based training and education to try to cut down your turnover times, improve instrument utilization, all the things we talk about when we talk about robotics cases. And most importantly, and probably the hardest to attain, is a culture of cost consciousness. So you can't have one surgeon doing a robotics case with 3 instruments and in the very next room using the same robot doing the same case. The other surgeon uses 14 instruments because it's not a culture of cost consciousness. So when we talk about who knows the cost data, we look at fully allocated cost models for robotics, right? So this is one where they include the capital cost, and this is the one where my opponent will talk about the most, right? So this is the one where the robot costs a lot of money and nothing else costs any money, and so the robot costs too much, right? I mean, that's the argument. When you look at the capital cost, amortization, maintenance rates, variable expenses, and this is data that was shared with me both from our institution and TJ Swope, but you can look and see that depending on what your robot costs and how fancy of a tool you buy, it can be between $2 and $2.5 million. Amortization changes based on that cost. Maintenance rates vary obviously by hospital, and the cost per case depends on your number of cases. But again, cost per case also does not include things like length of stay and so forth. It is simply the cost per case. So if you've saved 2 days in length of stay after a TAR repair, that isn't factored into a fully allocated cost model. Let's see. There we go. And the other thing, when we look at costs that aren't always appreciated, are the costs of laparoscopy. So our institution right now is looking into buying the brand new set of laparoscopic towers and instruments and cameras for our entire operating room. And I can tell you that capital cost is appreciable, as you might suspect, buying it for an entire operating room. Now, obviously, a per unit price of a laparoscopic tower and equipment, it costs less than a robot. But when you look at it from an operating room standpoint or a health system standpoint, that budgetary expense or that capital expense is still quite large, okay? And again, depending on how fancy the equipment you buy, that price can go up and up depending on how many you need. So again, that cost per case may be ultimately lower overall because you do more laparoscopic cases, and that's something that's included in the allocated cost model. Oops, I went backwards. There we go. So here is our VCU Health Annual Report. So I just talked to you about amortization, right, where amortization rates for capital costs are often cited at $300,000 a year and maintenance rates of $200,000 to $300,000 a year. And so here's what our health system actually publishes. And you can see that the entire health system's depreciation and amortization rate is only $67,000. So they're doing something, right? How can they cite an amortization rate of $67,000 when we bought 2 robots this year and 1 the year before? So in some way, those numbers become a little bit funny, right? And so if you're trying to track the money and you're not an administrator, sometimes you can feel like this, especially when you're simply a faculty member trying to get their own cost data. So let's see here. I'm having the Ed Felix problem. Yeah, all right. So the other argument is the contribution margin model, okay, instead of the fully allocated cost model. And this is where revenue minus your variable expenses is really your contribution margin. And this is where you can control variables like disposables and personnel and operating room time and all the things you're familiar with. And this plays a large role in the streamlined pathways that you create for robotics and the surgeons who do those cases. So what can you do to identify individual costs in the contribution margin model, which excludes capital costs? So this doesn't count the $2.5 million toy, all right? At Surgeon 1, and these are actual cost data from practicing robotic, experienced robotic surgeons who've done many hundreds of cases, you can see their costs listed there for TEPs and R-TAPs and lap ventrals and robotic ventrals. And yet the same type of surgeon in a different community setting in a different part of the country who's equally technically experienced with a similar streamlined process does the same types of cases, generally speaking, and their costs are very different. And obviously these exclude mesh costs and maintenance costs. So what I'm trying to get at is literally sometimes almost surgeon dependent. And so trying to define the exact and specific cost globally is very difficult to do. And what about it from a hospital level instead of just a surgeon level, the procedural costs, which are offset for clinical measures? And again, this is what the hospital looks at, things like length of stay, conversion rates, length of ICU stay, the complexity of the patients that you perform these procedures on. Obviously, readmission rate is a big hot topic, right? And so this is where outcomes come to play. And if your outcomes may shorten hospital length of stay or save them readmission, or we can show that, which of course the data have yet to show, then that will be a way that they can offset the initial capital cost that you're all familiar with. Looking specifically at one given disease process, rectal resection for length of stay, you can see that the robotics lengths of stay are in light blue and the open procedures are in this color over here, kind of a tan. And basically what you can tell there is if you can save a hospital length of stay by using a robot versus open in all different parts of the country. So some places it's more, some places it's less. But in the end, this may be an outcome metric that's worth tracking because it may offer value to the health system. It may offer value to the patient. So who knows the cost data for length of stay for ventral hernia with posterior component separation? We've been talking, you saw Conrad talk about his robotic TARs and the robotic TARs we do. And looking at our data, which is smaller than Conrad's and some others, we're saving almost an average of 2 hospital days. Now, of course, I don't see any of that benefit. They don't pat me on the back and say thank you, of course. It doesn't save in cost in that way, but it does save the health system in length of stay costs and also in patient turnover. So if the robot increases cost, does it also add value? Well, it can potentially increase your case volumes. It can change your payer mix for those people who may be looking for robotic procedures. It can improve surgeon satisfaction. We talked about Conrad and his durability, so that when he's old and ancient, like Dr. Felix, he'll be upright. And certainly we don't have any data, as Dr. Felix pointed out, that there are inferior outcomes associated with robotics yet. That's probably because there's not a whole lot of data to look at. It does at least show in our institution some shorter hospital length of stays for procedures that are often done open, and therefore may increase the use of minimally invasive approach for things like laparoscopic inguinal or open posterior component separation. So I would argue then that yes, hospitals should know what each robot procedure costs from nuts to bolts, and that is a hard thing for even them to determine, and often takes some help and some outside resources. They should share their costs and outcomes with the surgeon, because how can you get better, how can you get cheaper if you don't know what you cost? They should determine their downstream revenue and value from these minimally invasive procedures. So if you do a robotic TAR versus an open TAR, are they, the hospital, saving money, or are you still costing them more? And then ultimately, how do you ensure a culture of cost consciousness? So one surgeon isn't spending $8 million while the other spends $4.72 on the same procedure. This is a quote from Dr. Loftus, who used to run Banner Health, where Conrad practices, about the organization of a cost-conscious model. So in summary, looking at the potential future situation, I think the good is that there's a period of potentially increased reimbursement for MIS hernia, so some of the data is going to have to be reanalyzed. Now, obviously, that offset isn't enormous, but it will change reimbursement rates. The new robotic platforms in competition are coming soon. There are other ones downstairs, as you're probably familiar with, that may potentially drive costs down, particularly in the capital cost model. But what about the bad? Well, the bad is the cost seems difficult to determine accurately and reliably on a large scale, let alone an institutional scale is hard. And then ultimately, how do you determine value? And I think it's not just about cost, but about value, and that's a much more challenging question to address. So what can you do? Well, learn from other people's money, right? It's also the best way to travel, in case anybody's interested. So again, social media is an opportunity for that. International Hernia Collaboration is obviously a great resource. There are other collaborations. The SAGES 4 got one as well. Print media like surgical endoscopy. Determining your cost by meeting with your administrators and figuring out how you can be a helpful or potential solution, at least on an individual basis. And then track your outcomes, because it's going to be those outcomes that will allow for assessment of value. Thank you very much.
Dr. Bittner.
Now I see why you're having trouble. Okay.
The clicker should work up there.
Yeah.
The handheld one.
Getting it onto the screen is the problem. Can I just click?
There's a handheld remote clicker up there that no one's using.
Yeah, it wasn't working either.
Just click it a few times. It should.
Go backwards? No. All right, well, thank you very much. I'd like to thank Brian and Dave for the opportunity to speak. The title of my talk is The Robotic-Assisted Hernia Repair Will Go Away When the Money Runs Out. I could have alternately titled it Robotic-Assisted Hernia Repair Better Go Away or Our Money Will Run Out. I had the disclosure on the previous slide, which I won't even attempt to go back to, but doesn't pertain to the talk here today. Further disclose that I'm not an MPH, so I'm not going to offer any grand solutions to the nation's healthcare expenditure crisis. This is just a word about my robotic experience, my robotic disclosure, if you will. It began back as a resident. I had a significant experience doing some research with the robot. In fact, around 2002, 2003, the city hospital at my residency program actually acquired a robot ostensibly to convince a cardiac surgeon to come and build a program. That never happened, so the robot was sitting in the corner collecting dust, and the chairman asked me to come out and do some surgery, so I did with a few gallbladders associated with the requisite press blurb. Eventually got certified the following year and began practice, didn't find a lot of use for the robot. Became interested again a few years ago with the advent of the single-site platform, so went through the training again with the multi-port platform as well as a single-site platform, which I have used sparingly, but for all purposes I can accurately be labeled a non-user. And what I want to do with this talk is show you that there is data that confirms that across the board robotic surgery is a more expensive way to do these cases. It's of unproven value, and that there simply is no means to justify how we can pay for it going forward. So take a look at some of the data from other fields. Let's say I talk about prostate, the poster child for robotic surgery, the area where robotic surgery really initially took off and kind of went away and ran. There is a good body of literature, although not all of it of the highest quality, but a good body of literature looking at cost data, and it's summarized in more than one actual review article. And it's been a rapidly adopted technology in that field, but it's consistently associated with greater costs, and it's never been found to be a cost-effective from a health and economic standpoint. If we look at the gynecology literature as well, again, another area where the robot is thought to be an essential tool in order to enable gynecologic surgeons to bring MIS to their patients. There's actually a greater body literature in this field. This is just one study looking at 10,000 patients. It's a national database survey. The robotic charge is clearly greater than compared to standard laparoscopic techniques. This and other papers have led the American College of Gynecology to write their opinion paper and clearly stating that robotic surgery is not recommended as a first-line treatment for hysterectomy, mainly because the costs do not justify the outcomes. There's sparing data in the world of general surgery, but increasingly so. We see some papers looking, say, the single incision cholecystectomy robotic costs, clearly much greater, nearly $4,000 greater in one study, and even in, again, area of colorectal surgery. Potentially an area of the body where the robot is thought to be of benefit down in the pelvis. The costs are clearly greater, nearly a 1.5 multiple with relatively little benefit in terms of patient outcomes. On this one study, the only benefit was a slightly decreased incidence of a conversion rate. Sorry. Yeah, it's not just you. Anyway. The general surgery literature, much of which is focused on the foregut. There are more than a number of robotic studies. This one report culled the 47 into the systematic review for those studies that were reporting on costs and outcomes. Hospital costs, conclusions, hospital costs across the board are higher than alternatives, and the clinical effectiveness data is really extremely limited. They even conclude that the evidence to suggest adoption of robotic surgery is really insufficient, yet here we are debating whether we should adopt robotic surgery for hernia repair. Just to show you that, in terms of the published data with the other side, there is a report that just came out suggesting that the cost of robotic cholecystectomy might actually be less than that of standard laparoscopy, mainly due to supply costs. But if you look into the paper, you have to be very cautious about the potential for bias. This is a group that was, extremely interested in minimizing their costs, which arguably we should all be. So they really honed their robotic technique, as James was mentioning, to minimize the use of instruments and disposables. And then while they admit right in their own paper, while they attempted to do that for the control group, this is very hard to control and measure, because the control surgeries were done by 5 different surgeons, several of which at least aren't even authors on the paper. So the comparator group may have an inherent bias for this one study. So this is, as Dr. Felix mentioned, this is my summary slide for the available data on costs of robotic-assisted hernia repair. Oh wait, there's none, right? Because there's no data on costs. I mean, the published literature to date on robotic-assisted hernia repair is extremely limited. It's mostly case reports and sort of a look what I can do with the robot. But I think that's about to change, and given there are difficulties in calculating the costs of any surgery that we do, actually, but there is going to start to be some data. We heard yesterday in one of the talks, a group gave results from their institution on, I think it was ventral hernia repair, showing a clear cost increase for robotic surgery. And I'd like to thank Dr. John Gould out of the Medical College of Wisconsin, who was kind enough to share this slide with me. This is data that's going to be presented formally tomorrow morning, so hopefully you can all look up this talk and go see. It's a well-designed presentation that details more than just inguinal hernia repair at their institution. But they did a controlled study looking at costs, and they're talking about only consumables, so we take out of the equation the contained cost of purchasing a robot or even the maintenance cost. And there's a clear cost increase associated with robotic inguinal hernia at their institution. And this is not even taking, again, also not taking into account that the case duration is longer for robotic hernia repair, and for some reason they also had an increased length of stay, which even I wouldn't necessarily attribute to the robotic surgery. But so I think across the board, there's no question that in every other field, robotic approaches to surgery are going to increase costs, and the same is going to be true for hernia. So if it costs more, we have to be able to do something better. We need to either bring in more MIS cases or do the cases better, improve patient outcomes, right? What are the outcomes we might try to improve for hernia? Recurrence, recovery, return of, excuse me, return of function, and obviously the morbidity of the operation. And I don't really see any value added with the robot. I mean, visualization, Dr. Felix touched on it. I mean, we can see everything great. We've got high-def cameras. We can see nerves. We can see perfectly fine in the world of hernia with the currently existing laparoscopic technology. The dexterity of the robot, does that add anything? Maybe for creation of flaps. Well, there's been several videos even presented at this conference where we can see there's nothing advantageous about robotic wrist movements over our standard laparoscopic instruments. We can create flaps, we can dissect. There's just no reason that we should believe we can do it any better with the robot. Ergonomics, another often cited benefit of the robot. That's fine. Maybe the surgeon's a little more comfortable, possibly, as again, Dr. Felix is mentioning. Could be to our own detriment in terms of health, but it's certainly not going to positively affect patient outcome. It's not going to improve the results of our surgery. And the other one, the ability to suture, that's one of the ones that's often cited to me by my residents. They say that laparoscopic suturing is hard. I would argue that it's not, and we showed that years ago when we did a comparative study looking at laparoscopic skills performance versus robot performance, and there really is no difference. Laparoscopic suturing is a skill like any other. It just needs to be taught and then practiced, and we can all get good at it, and that will enable us to do things that people are saying you can do with the robot. Defect closure, mesh fixation without tacks. We were talking about the TAR repair earlier today, and that maybe it can't be done laparoscopically. That's simply not true. There was a great video actually yesterday presented by Yuri Novitsky showing his laparoscopic technique for TAR separation. It's no question, it's a complicated operation, and that's true, and we'll have to learn how to do it, but there's nothing about the robot that's going to make it less complicated or easier to perform. So, simply put, there really is no enabling of robotic technology in the world of hernia. In my opinion, there's not going to be any added value. So, if it costs more, there's no added value, who's going to pay for this? I mean, I would argue who in the right mind would pay for it? Why should we pay for something that costs more and doesn't really enable us to do anything better? We've got a big problem with healthcare in our country. We spend nearly twice as much on healthcare as any other of the developed nations. Those costs are only going to go up over the next decade, 5.5 trillion by the year 2024. So something has to give. Who's going to pay? Right now, the CEOs and the hospitals are paying. They've made the capital expense. They need to do something with it, as they say. So they need to reduce their dollar cost average, so they encourage its use. And they may gain some benefit in terms of ability to market. They may draw in a few extra patients, but eventually that's going to go away too as the next newest and best thing comes along. What do we hear in my area? What we hear on the radio now is not actually robotic surgery, but radio surgery for prostate. That's the newest wave, and they're advertising that. Will our payers, Medicare, pay for this? Absolutely not. In fact, we're in the era of value-based pay right now. It began in January of this year. So value-based care, simply stated, is just if you don't provide good value, you're going to get less pay for what you do. This has gone into effect for January, affecting certain Medicare physicians this year, and I believe by January 1st of 2017 will affect all Medicare physicians. So this is over and above the standard PQRS measures which were already in place. If we look at this graph a little more carefully, what it means is that if you offer a high-cost service, such as robotic hernia repair, you will lose money, a negative multiple of the standard CMS rates, if you provide low quality or average quality service. That's on a per capita base. And even if you somehow do improve the outcomes, the true patient-related outcomes of the surgery, you're only going to be paid the same as others who offer average or low cost. So there's no way that our healthcare system is going to pay for low-value care. Who does that leave? I mean, the patient? No, right? Patients aren't going to pay for increased procedure costs. I'm not sure there's even a mechanism for that, but most patients don't want to pay anything over and above their copay. So they're going to get angry if you tell them, look, I can do your surgery and I want to use a robot because it makes it better for X, Y, and Z. They're not likely to want to pay. And then the only one left in that equation is us. And when we get all into an accountable care model, and if we are offering surgeries that cost more, that's going to be money directly out of our pockets. And I, for one, don't particularly want to have any more money taken out of my pocket. So, sorry. It is true. So to conclude, I'd say this is expensive, unproven technology. It's not likely to improve patient-related outcomes in hernia. As a society, we will run out of money eventually if we keep paying for technology that's expensive. It doesn't improve care. It is up to us, I think, primarily the surgeons who can help contain these costs, but we have really very little incentive to do so. Most of us are not beholden to hospital costs, so that may be a barrier to our ability to try to reduce costs. But I think our resources are better spent elsewhere. Save the robotic technology for areas where it may be more helpful. There's actually some good literature, say in the ENT world, where robotic resection of certain oral cancers actually is cost beneficial and has better outcomes than the standard therapy. We can save this money and spend it on something that might actually improve hernia outcomes. For instance, long-acting local anesthetics, so we can send our patients home with no somatic pain. That might be a better way to spend the resources. And that's it. Thank you very much.